Welcome to the CodeCast podcast. Real-world insights for your daily medical coding and billing processes. And now, here's your host, Terry Fletcher.
Hello, everyone, and welcome to the 179th episode of the CodeCast podcast. My name is Terry Fletcher. I hope everyone who had a spring break last week enjoyed their time with their college kids if they came home to visit, or your school-age kids that had a week off if you did something away from your house. Hopefully you got outside and enjoyed some nature and just had a really nice week. It looks like the weather across the country was pretty good. I just wanted to apologize a little bit. I strained my voice over the last week. My daughter was here for her spring break since she's a teacher and her class was out, and more fun stuff on that later in my personal tidbit, but I just can tell my voice is very scratchy. So if you hear a couple of pauses in between, it's because I'm muting myself so I can cough really quick, so I'm not coughing in your ear this week. So today on the podcast, I'm actually going to discuss a topic I haven't talked about before, and in 3.5 years of this podcast every week, it's hard to find something that you haven't talked about before. So it's kind of fun when you actually find a topic that can appeal to people that you haven't really, talked about before. So that's exciting. So what I want to talk about was the Medicare has something called an inpatient surgery list. And every year CMS releases an updated inpatient-only surgery list. And the surgeries on this list are not arbitrarily selected. So due to the complexity of the procedure, the risk for complications, and the need for post-operative monitoring, and an anticipated prolonged time for recovery, Medicare understands that surgeries require a high level of care. And during the public health emergency, some of the ambulatory surgery centers, as you know, were made into what they call hybrid hospitals, or hospitals without walls, they call them. And that gave CMS a way to determine if some traditionally inpatient surgeries could also be done safely in an ASC. And the answer was yes. So this list continues to be fluid and updated more than just once a year. It's going to be updated again in July. And this can change with the climate and, overpriced hospital facility stays for our patients. So this list was shortened immensely by the Trump administration, and hopefully will continue to lessen as outcomes and efficacy information becomes available. And again, it's about safety to the patient. And it's important for you as coders, though, and billers and providers to know what's on these lists so you will know if you will get paid as well, because you may think something is automatically inpatient and it isn't, and the patient may not have a Part A coverage for a certain surgery. So I'm going to give you just kind of the gist of what's on some of these lists and then just explain it a little bit further. But first, the CodeCast is also brought to you by JP Morgan Private Bank. Connect with over 200 years of experience, service, and stability. JP Morgan Securities, JP Morgan Chase Bank, privatebank.jpmorgan.com. Okay, so let's take a look at this from a perspective of really what Medicare looks at from coverage, okay? So we know that surgery doesn't come cheap, as you know, and if Medicare is going to pay for it, your patients need to know if it is a Part A, Part B, or both. And if it's Part A as well, meaning inpatient, that's the inpatient reimbursement for a patient, then that they're going to want to know that, because that's where the enormous expense comes into play. And it's also, important that when a patient thinks about having surgery, that they look at the logistics of, where it'll be performed, how much will insurance pay, towards the bill. And a lot of patients need to really look at that before they undergo some elective surgery and procedures on that. And like most things under the Medicare umbrella, not everything is black and white. So few people are actually aware that the Centers for Medicare and Medicaid established a list of surgeries that will be covered under Part A. And again, other surgeries, as long as there's no complications and the person undergoing surgery doesn't have significant chronic conditions that could put them at high risk for complications, they default to Medicare Part B. And so that means that they can be done in an ambulatory surgery center, in an office-based lab, as I mentioned that topic last week, or even possibly in the office as a global surgery. But you have to make sure you know those rules, because those can be a little bit dicey. So when we're looking at this list, some of these procedures, again, require high-level care. So here's an example of some of the inpatient-only surgeries currently. So coronary artery bypass grafting, you've probably heard it called a CABG, that's the open heart surgery. Gastric bypass surgery for obesity, heart valve repair, valve replacement surgery, colectomy. So when you're removal of the colon, and a lot of the GI procedures that have to do with colon removal and intestinal removal, then those are also on that list. But what you may be surprised to learn is that very few spinal procedures are on that list. Some types of spinal fusions and discectomy are not inpatient only anymore. And other common procedures once on the list, now they used to be, but they've since been removed because, again, the data and the information showing that it can be done safely and performed safely in an ambulatory surgery center is important to know. As of 2018, total knee replacements on the orthopedic side, total knee arthroplasties, are no longer on the Part A side. They can be done in the ambulatory surgery centers. Total hip replacements. Now, these have always been inpatient. And as long as the patient doesn't have certain comorbidities, and I think there's an age, let me look real quick. There is an age threshold on this. So total hip replacements were taken off the inpatient only list as of 2020 and now considered Part B procedures unless the patient is over 85 with comorbidities. So always look at the caveats on that. For the safety of Medicare beneficiaries too, the inpatient surgeries must be performed in a hospital because the patient also has a deductible in 2021 of $1,484, in addition to 20% of, doctor's fees. And so there's a lot of things there that the patient would probably need to know about. Otherwise, there could be some hidden costs. Remember the surprise medical bill, which I don't know if I've talked about this. I know I talked about it on my Talk 10 Tuesday with ICD-10 Monitor a couple weeks ago. But the surprise medical bill only affects out of network. It doesn't affect in network, doesn't affect Medicare or any government plans. The patient's still going to have an out of pocket. And so hospital charges are very high. One thing the former administration did is they were very much into transparent bills. And now the current administration, not so much, which I don't understand that, but we're not getting a lot of compliance with transparency when it comes to cost after it was already implemented. So I'm hoping that actually changes. But let's look at some of the outpatient surgeries that can be performed at an ASC. And what they look at this list, they call this an addendum AA. So it means they add this list saying that these surgeries, if there's risk factors, could be done in the inpatient, but you'd have to get approval first because these are now listed as Part B or ASC outpatient medical facilities. And they may or may not be affiliated with the hospital. And they also consider these what they call same-day surgery centers. So this is what the guideline for Medicare says about this. It says the surgical codes that are included on the ASC list of covered surgical procedures are those that have been determined to pose no significant safety risk to the Medicare beneficiaries when furnished in ASCs and are not expected to require active medical monitoring at midnight of the day on which the surgical procedure is performed. So they mean an overnight stay. Simply put, what they're saying is that these surgeries are low risk and are not expected to require care and monitoring beyond 24 hours. So what's on this list? Well, cataract removal, colonoscopy with or without biopsy. So a lot of those diagnostic colonoscopies or screening colonoscopies, epidural injections for back pain, prostate biopsy, shockwave therapy for kidney stones, believe it or not. Typically any kind of arthroscopic surgery repairs in the knees and in the shoulders. And then any kind of, even if they are global period days where they're 90 days on the general surgery side, you want to look at the list that includes things like breast biopsies, excisional biopsies, possible partial mastectomies, any kind of carpal tunnel syndrome, again on the orthopedic side, neurology services, sometimes when we have neuromuscular injections, things like that. So these surgeries are covered by Medicare Part B. The patient will be required to still pay a 20% coinsurance and any aspects of anesthesia and IV therapy that is part of that. But a lot of services are also bundled into the ASC payment. We call it the OPPS payment. So it's kind of like I don't want to call it a bubble, and it's not really a capitated payment, but it's a group payment that includes, medications to the room. They call it room and board for the day, supplies, things like that. Those things can really be all included in that grouper. They call it a code grouper. Now, looking at the surgery list, remember, it's not just about payment, it's about safety. So staffing in a hospital is very different than in an ASC. So hospitals have 24-hour resources, and ASCs typically have reduced staff overnight. And most ASCs don't have a physician on site after hours. So if there's a complication after hours, the ASC probably won't have resources and personnel available to manage it. And that's when you would have to transfer the patient to a hospital. And that's where the big issue is as far as being on that list or not being on that list. So it doesn't mean that other surgeries aren't performed in a hospital setting, especially if it's outpatient, but you have to just make sure that you are relating to the patient. If it can be done in an ASC, you might want to consider it, especially safely, typically because the out-of-pocket to the patient can be almost hundreds of thousands of dollars less than what it could be if performed in the hospital. And it's important because one of the other things that is really an issue here is, let's say that you have an inpatient surgery and the patient is under Medicare Advantage. Okay, so that's typically run by commercial plans. And so they basically have a different list. Sometimes they definitely have their own internal list, but they don't always follow what Medicare says. But if you have a Medicare Advantage plan, a lot of times what happens is that there could be consideration for rehab after surgery. And in order for traditional Medicare to pay for a stay in, let's say, a skilled nursing facility, you still have to have 3 consecutive days as an inpatient in the hospital. That's a kind of an unwritten rule. People don't realize that. Now, Medicare Advantage plans have an option of waiving that 3-day rule, and that could help a patient as well. But just know for certain services, if you're planning on, or the patient's planning on to rehab at a skilled nursing facility or something like that, then you may not have an option of an ASC for that patient. And it's really about complications, safety to the patients, and making sure that you know what's on that list. So make sure that you're looking at that. You want to look at the calendar year. So when they look at a CY or FY, you want to look at the IPPS final rule homepage under Medicare, and then also make sure you're looking under the ambulatory surgical center payment final notice of rulemaking. And 2020 and 2021, we've had a lot of information. Now, make sure when you're looking at it, you look at the 2-part when you look up these rules, because, for example, under CMS 1717, that rule was clear where they had during public health emergency and then after on what would be there. So we just don't want you to get too excited if you see something that's saying, oh my gosh, I can do this surgery, and actually in effect that it wouldn't be effective after the fact. So we just don't want you to put into money unless you've done your due diligence. But I just want to bring some of that to your attention, because some of you may not know when you're getting pre-authorizations for surgery, and let's say you own your own ASC or you own your own outpatient surgery center, that you can actually do maybe a major surgery you weren't aware of, and that could save the patients a lot of money, and your reimbursement is going to be higher as well. Okay, so I wanted to get into my coding question for today and staying with the surgery theme. So remember last week how I did a 62 modifier FAQ, a question and then an answer to that. Well, I want to continue with that theme, and I have 2 more, and the next week I'll do 2 others. So here's one as far as identifying the other physician as a co-surgeon. So the question is, my cardiologist performed a co-surgery with another physician. My colleague was helping me code this claim. She said it would be a good idea to call the other physician's billing department to ensure he is identifying our cardiologist as a co-surgeon and that he's also billing with a 62 modifiers. Is something I should do? Absolutely. So it would be a good idea to contact the other physician One of the rules of a 62 modifier specifies that each physician must identify the other as a co-surgeon. So this is especially important, as indicated previously, because if, for example, your cardiologist reported the other physician's work as a co-surgery, but the other physician reported your physician as an assistant surgeon, then your 62 modifier claim is going to get denied. Also, you could check in with the other physician to double check that both the cardiologist and your physician are reporting the same CPT codes to represent the procedure. They have to mirror each other. And then another question, and I'll just do two today. If my cardiologist acted as a co-surgeon with another physician, should my cardiologist also have to submit his or her own operative note? Again, absolutely. When two physicians bill a service as co-surgeons using that 62 modifier, they should document their own operative notes. Since each physician performed a distinct part of the procedure, their documentation won't be the same. So your cardiologist must include what portion of the procedure he performed, how much work was involved, and how long the procedure took. And then they can also explain why co-surgeons were needed for that particular procedure. That's really an important part of it, is that you need to make sure that there was some kind of a sentence or a paragraph that says why two surgeons were important in that procedure. Think TAVRs, think the valve replacements and things like that. If you're orthopedic, think, A to P in lateral spine surgery, and just some of the things that it's helpful to have that extra hand in there. Otherwise, that could be an issue. Our coding question today was brought to you by Keck Medicine of USC. Over 500 nationally renowned doctors at a leading academic medical center, keeping you healthy, on track, and doing the things you love. The Keck Effect, keckmedicine.org. Okay, so my personal tidbit this week is that my daughter did come home for spring break and she got engaged to her boyfriend, Christian. So a shout out to them. I'm a happy mama right now. So that's exciting. 26 and she's on her way. So I'm pretty excited about that. Also, I wanted to shout out to some of you that have been sending me just some really sweet messages this week. Gosh, I don't know what's in the water or the full moon or what's going on or in the air, but I can't tell you how much I appreciate some of the support I've been getting this week. It's been awesome. So I want to shout out to Eileen V, Robin, Kelly Z, Laura H, and Janet M. The other thing, one of the things that Eileen sent to me, and I can't tell you how much I appreciate this, is she said, I'm not only in support of the CodeCast, but I'm in support of you and how you do not allow certain social media platforms infringe on your freedom of speech rights. And I just can't even tell you how much I appreciate that. I have had a little bit of backlash because, I do have a specific political affiliation only because I like policy and I like things that help Americans. And so when I see that, I'm a proponent for that, regardless of who's at the helm. If I see it, regardless of who you are, I want to tell you about it. So thank you, Eileen, for that. I really appreciate the positive feedback. It just really made my weekend. So that's it for me this week, folks. Make it a great day and a great rest of your week. And I'll talk to you next time on the CodeCast podcast.
For more information on medical coding, billing, auditing, and compliance, including how to hire Terry, follow Terry on Twitter @TerryCoder1 or visit her website at www.terryfletcher.net. Podcast producer Joe Kuzma. Music producer Dassassin Music.